Okay, welcome everyone. We are so glad that you've joined us this evening for this special program, Dementia Research Forum Focus on Prevention. I'm Michelle Diskin-Greco, the VP of Programs for the New York City chapter of the Alzheimer's Association. It's wonderful to have so many of you here with us today, both in person and joining us virtually, to learn more about the exciting work happening in research for Alzheimer's disease and all related to dementias. I'd like to start by expressing our gratitude to the team here at Weill Cornell Medicine, New York Presbyterian Hospital, for being such wonderful collaborators for this program. Special thanks to Dr. Sonia Bloom, Associate Director of Clinical Neurology, Director of Memory Disorders and Cognitive Neurology Division, Dr. Gloria Chiang, Vice Chair of Clinical and Translational Research, and Associate Professor for the Division of Neuroradiology, and Dr. Moni De Leon, Professor of Neuroscience and Radiology, founder and co-director of the Weill Cornell Brain Health Imaging Institute, along with today's three speakers. I'd actually like to invite Dr. De Leon, who's going to say a few brief words of welcome.
I must say I'm so totally unprepared to do this, but let me begin by making a couple of general remarks. It's about 50 years now since the National Institute of Health formed the NIA, which was directed by Robert Butler, who was actually a quite esteemed imaging scientist in his own right. In 1980, the Alzheimer's Association began, and it was actually quite small in 1980. I remember this first Congress that was held in Las Vegas that only had about 200 people in it. And the last meeting may have had maybe 7,000 or 8,000 people in it. Clearly an exponential growth over the years. The role of the Alzheimer's Association has also grown tremendously in importance. It's become more than a national organization. It's become an international organization. And I'm reminded of colleagues and many people here in the room who remember the contributions of French, the English, the Germans, from Belgium, Japan, and of course, Sweden. So the Alzheimer's Association has evolved into an international organization. And as an international organization, it serves the needs of many younger generation scientists by providing funding, and especially in times like we're in now and emerging into now, alternate sources of funding become increasingly important in a world where resources are being challenged and perhaps shrinking. I want to say that over the years, the NIH and the Alzheimer's Association have really put together a harvest of great ideas and created, the way I think of it, as like a cornucopia of like discovery and meaning and development of improved strategies for interrogating human systems, learning from animals how humans are evolving into disease states, and ultimately targeting, with some success, although much more is needed, the therapeutic side of all of this work. The history of funding has really shown its ups and downs. I did a search. I was curious because I keep remembering in my career how many times I was told the government wasn't going to fund my grant anymore because they ran out of money. You know, and so I wanted to see if it was reflected in the statistics of the budget. So I found 4 good examples of periods of time where the entire NIH budget was challenged. I ran the search from 1980 to the present. It's not well documented. It's a little hard to figure it out, but I found dates of 1991, 2003, 2011 as key dates of loss. NIH has been sort of correlated with those dates. This was an NIH search, so NIA was more or less in there. But from each dip in the funding capability, there was an increase. It was followed by a period of growth. Sometimes the growth was very small. In the last 10 years, the growth has been very good. So we have grown as a community over the past 10 years to the highest level that we've ever seen. So here we are at the pinnacle of our funding success, now being challenged. We have brought into the field people from many diverse types of vocation and background. It used to be a field filled with, biologists and neurologists and psychiatrists, an occasional radiologist, and pathology. But now the population of contribution is very widespread. Just think of the economics work that has been done. Think of the social relation work. Think of the outreach. There's been a tremendous proliferation. So why are we being threatened today? Is it because our population dynamics are not consistent with the funding? In other words, are there less old people? Is there less dementia in the world? Well, that's not it. Is it because of fraud? Could it be possible that you are part of a cohort of scientists that have made your money and made your fame by deceit and invoking distrust? That's the voice that we're being told by government officials, and especially by the pending Health and Human Services Director, Robert F. Kennedy, as a fundamental problem in the field. It's the corruption in the Alzheimer's field that has specifically forced many other scientists, like all of us in this room, to follow the amyloid hypothesis to this endpoint where we have no effective drugs. And this is the rationale. He wrote a book. It received, I don't know if you saw it, it received like a large expose in the New York Times about 2 weeks ago, several pages dedicated to this fiasco that's emerging. So they highlighted 4 scientists in this fiasco as being responsible for this, leading the herd to off the beaten path. So I looked into those scientists. 2 of them I actually worked with, and one of them I published with. And I'm thinking, oh my God, is every avenue, under surveillance? In the case of, well, it's not important, but there was no, for me personally, in the group that I worked with, there was no impact. But my thinking was, okay, so there were 4 bad apples in the bunch. Okay, whether it's true to what extent, I don't know. But consider 4 bad apples in the thousands of people that have dedicated their careers. And is it different anywhere else? Is human nature different in cancer? Cancer research, is it different? So I don't think so. I think what we're seeing is a selective attack based on a perception of a vulnerability that I find to be very distressing. So where do we go? I think what's really needed is for us to highlight our strengths. I think what's needed is for us to co-recognize our accomplishments. I think it's necessary for us to stand up and deliver to the world a coherent and clear message of what we have contributed as a community, both in the understanding of the biology of aging and in the neurobiology, the neuropathology of Alzheimer's disease and related dementias. That's our mission. I think we need to communicate that better. I think we need to tell the public who we are and what we are. So, as I said, I didn't really have a lot to say today. And it's not, and I leave it, I try not to be political. I'm trying to be as close to the facts as I can force myself to be. But I do think we have a responsibility at this moment in time to say who we are. Thank you.
Thanks. That all just reinforces for me the importance of us being here together today. And I'm thrilled that we're actually going to start with a presentation from Dr. Heather Snyder, who's going to ground us all in the research that is happening, an overview of research in diagnostics, treatment, and public health today. As per your agenda that you all received at registration, today's program will start with a keynote address from Dr. Snyder. That will be followed by 3 brief presentations from our esteemed colleagues here at Cornell. And then we will close with an opportunity for a panel discussion. We did give out index cards at registration. My colleagues will be wandering the aisles. So if you have questions, please write them down and we'll be monitoring the chat as well. But now we're going to get started with our featured presentation. I'd now like to introduce today's keynote speaker, Dr. Heather Snyder, Senior Vice President, Medical and Scientific Operations at the Alzheimer's Association. Dr. Snyder, thank you so much for being here with us today.
Thank you so much, Michelle. Thanks to the incredible team here in New York, but also the incredible team here at Cornell for welcoming us and having us all here today. And it's great to see some faces that I know that are from other institutions across New York as well. And we'll talk a little bit about some of the work, and I'm going to try to point out as much as I can in seeing who's in the audience and tying it into some of those folks that are here in the room as we talk. So my job is to try to set the stage and give an overview, high level, of where things are, where we're going as a field, and where we're going as a research field moving forward. And I think one of the takeaways from Dr. DeLeon's talk is the importance of communicating the science and communicating the excitement of what's happening in our landscape and in our field. Talking about it, explaining it, sharing it with one another, whether it's among scientists, but from scientists to the community and back again. What's clear? What makes sense? What's your lived experience? And how do we bring that into our research as well? All equally important conversations as we move research forward, because without each other and without those conversations, we're not going to make the progress at the pace that we need to be making it for any of us that have lived this journey with Alzheimer's or any of the diseases that cause cognitive impairment. So just to note a little bit about my disclosures, I am a full-time employee of the Alzheimer's Association, and my husband is an employee at Appel Labs in an unrelated space. So when we look at this landscape, when we look at what we're facing with Alzheimer's and related dementia, there are over nearly 7 million Americans today that are living with Alzheimer's, and there are over 11 million individuals that are providing care and support for an individual with Alzheimer's or another dementia. So the sheer number of individuals that are affected by this, I know it's been in my family. I'm sure many of you here are here or working in this space because it's something that's very personal to you, or you have friends or you have family. I had an earlier conversation with someone, they've been affected. They now have all these friends that are affected in their families. And so this is a very personal and real issue to many of us in our day-to-day lives. And without research, we're not going to get ahead of it. We need to make sure we've got the support and resources in the communities, that we're providing the best care and the best support for individuals that are facing this disease. I know I met somebody that's working actively with patients in the reception earlier today, but we also need to get ahead of it and understand what's happening in these diseases, understand what are the changes that an individual is experiencing. How do we stop or slow that progression? How do we diagnose someone accurately and as early as possible so we can stop or slow that progression? And ultimately, how do we get even more ahead of it and prevent it at all as we go forward? And that's, of course, of all of our goal as we look at this space. So the Alzheimer's Association. The Alzheimer's Association has a vision of a world without Alzheimer's and all other dementias. So although we are called the Alzheimer's Association, we encompass all of the diseases that cause dementia within the work that we do, whether it's within the care and support services that we provide, or the research we fund, or the advocacy that we advocate for at the local, the state, and the federal level. You heard a little bit about some of that advocacy work, and we've seen it because of voices of people like you all across the country telling their stories and underscoring the importance of research. We've seen a marked increase in terms of the investment at the federal level in Alzheimer's and related dementia research in this country. And that's being translated into progress and findings. And we'll touch on that. And then you'll hear some 3 real examples of some of that work that's going on right here in New York. So the Alzheimer's Association has also seen an increase in our own funding that we've dedicated into research and in this space. When we look at our research strategy, we look at how can we seed research forward, how can we speed it, and how can we scale it up to really meet the needs of individuals across the board. Today, the Alzheimer's Association is the world's largest nonprofit funder of Alzheimer's and all dementia science. We have a little over $430 million that's actively and committed to over 1,100 projects in 56 countries. And I know some of you in this room are researchers that are currently have applications pending with the Alzheimer's Association, and those numbers are anticipated to change in the coming weeks as we finalize those reviews and send out notifications, so don't worry. So a little bit about some definitions, and this is important as we talk and with some of our other speakers today. So dementia, and I've used that term multiple times already, dementia is really that umbrella term. It's really describing the symptoms that an individual is experiencing. It's that changes in memory, reasoning, and thinking that individuals experience that affect all of their activities of daily life and ultimately their independence and as they go forward. The causes of dementia are the individual diseases. So Alzheimer's disease, we know vascular disease, frontal temporal disease, Lewy body disease, and those cause the changes that an individual experiences: Alzheimer's dementia, vascular dementia, Lewy body dementia, frontal temporal dementia, as just some examples. Increasingly, we understand that many people actually have brain changes associated with more than one of these diseases as they progress. And that's incredibly important as we think about diagnosis. So what might be driving an individual's changes, symptoms, what they're experiencing, and how do we treat, how do we intervene, how do we help that individual go forward? You're going to hear a little bit more from one of our next speakers, Dr. Fink, about vascular dementia and vascular disease and really that impact and what we understand and a little bit of some of the insights in that space shortly. So today, when we look at Alzheimer's and actually really all of these diseases, how are they currently diagnosed? Well, there's no single test that can determine if an individual is experiencing memory changes due to one of these diseases. But we have a landscape of really complex cognitive tests. So anybody that's gone through that knows what kind of experience that is. And increasingly, we have tools that allow us to measure the underlying biology that an individual is experiencing. So we can look at what are their cognitive symptoms, what are they experiencing clinically in their daily life, and we can pair that with measures of their underlying biology. We can make a good guess as to what is causing those memory changes in that individual. So thinking about Alzheimer's disease, we now understand, and it's really with these tools that allow us to look at that underlying biology, we now understand that that underlying biology in Alzheimer's disease is changing maybe 20 or 30 years prior to someone having memory changes. So there's a period of time where people are having underlying biology change before they're experiencing memory changes. You can think about it like heart disease, right? You might have elevated cholesterol or some other sign of underlying heart disease, but that can be many, many years before someone has a stroke or a heart attack, right? And there are things you can do along that way. That's a sort of an analogy for the same kind of idea. There's a period of time where someone may have mild memory concerns called mild cognitive impairment that don't necessarily impact their everyday life, but do impact they impact aspects of their everyday life, but not necessarily their independence. And then, of course, the stages of Alzheimer's dementia, mild, moderate, and severe as individuals progress. So in thinking about how can we look at what might be the underlying cause of an individual's memory complaints, we have tools called biomarkers that allow us to measure that underlying disease, measure that underlying biology. So an example is glucose. That's a measure for insulin resistance and diabetes. Cholesterol is a surrogate biomarker for heart disease as examples. And increasingly, we're starting to have tools in the Alzheimer's space that allow us to measure that biology as well. We also have, there's different ways that tools can be used. They can be used to diagnose an individual. So as part of the diagnostic workup, this point in time, there's no biomarker that should be used alone. It should be used as part of a clinical workup in a dementia specialist's care. They can be used as an enrichment in the clinical trial. Can we identify who is most appropriate for a given clinical trial? They can be used to predict what might happen to somebody. And there's a lot of research, but very much in the research space, work going on in trying to say, can we predict who might go on to have those memory changes? And then they can be predictive about what might be the outcome, who's going to respond to a given treatment. So there's a lot of work going on to try to understand these aspects in Alzheimer's and the other diseases that cause dementia. So in our space, there's really three classes of biomarkers that we look at. So imaging, so there's a lot of tools in terms of looking at imaging, whether it be PET imaging, taking a picture of the brain and it lights up and you can see some of the underlying biology of an individual, or MRI to look at volume changes and some of the other components. And you'll hear a little bit more about imaging from one of our other speakers in a little bit tonight, and the tools that imaging can allow us to understand what's happening in an individual. I think you'll get to see some pictures of from patients and what they mean, what they tell us as we're using these tools both in research, but also in the clinic. Then fluid is probably the other thing. So we talk a lot about fluid in terms of blood, But also our brain sits in a fluid called cerebral spinal fluid. And so there's tests that allow us to take a picture, a window into what's happening in the brain with CSF. And so looking at some of the brain changes that are associated with Alzheimer's and other diseases. And there's a lot of work going on in this space. In fact, there's at least one FDA-approved test to measure Alzheimer's-related brain changes in the cerebral spinal fluid of individuals. But probably where some of the exciting work is happening, and we're hearing a lot more in the news and in the media, is around blood tests. And when is a blood test going to be available? It's probably one of the most popular questions that we get in the community. And I know I see a few people nodding that it's probably a question you either have or you get as well. There's a ton of work going in terms of trying to understand what a blood test tells us and what it might mean in terms of a diagnosis for an individual. Who might it work in? And is it something that is actually able to add to the diagnosis? And there's some places where we are seeing it start being used in clinical care. There are examples of direct-to-consumer tests that are also being made available. So understanding and asking those questions becomes really important as a savvy consumer. And I'll just touch on that there are a lot of other things that are being developed, things around skin biopsy and other types of imaging with the eye that are being developed. I'm not going to spend too much time on that. But ultimately, we want to, at the end of the day, have what is the right test for the right patient at the right time. How can we identify an individual at that earliest time point so that we can intervene in a way that's appropriate for them at that time point to hopefully stop or slow the progression of the underlying biology, stop or slow the progression of the underlying disease. And that could be whether it's Alzheimer's disease, whether it's Alzheimer's and vascular disease, and understanding that biology is incredibly important. You'll also hear tonight greater detail from Dr. Gann, more about some of that underlying biology specific in Alzheimer's and some of these other diseases. So when we look in and we think about an early and accurate diagnosis and why these tools are so incredibly important and why there is so much attention on a blood test, it is because an early and accurate diagnosis there's medical benefits to individuals. There's certainly emotional and social benefits to an individual, and then financial benefits in being able to make those plans for your care future and participate as an individual, particularly for the early stages of the disease, in those planning processes as part of that conversation. And for any of us that have gone through that diagnostic process with a family member or ourselves, knows that if you can make something more simple, if you can introduce something that will give you an answer more quickly or more readily, how incredibly helpful that would have been to that conversation and to that process. We're not quite there yet in terms of blood tests being right for prime time. And there are some clinics that are starting to use them as part of their clinical workup and as part of that, but they're really in specialty clinics. So those are the kinds of questions as a consumer to ask your clinician. What's the test? Who's this been tested in? What does it tell us? What kind of information do we have about this tool as an example? So all of this landscape becomes also incredibly important as we think about trials and the ongoing clinical trials and the emerging space of therapies in Alzheimer's and dementia. So these are specific to the FDA-approved therapies for Alzheimer's. This is a busy slide, so I'm just going to walk through it a little bit. So what you see across the top is that continuum of disease that I talked a little bit about. Individuals that might have biology change but not have memory changes, individuals experiencing mild cognitive impairment due to Alzheimer's, mild, moderate, or severe dementia due to Alzheimer's. And in our space today, there are 3 different medications or 3 different kinds of medications that have been approved. The first is medications that treat symptoms, and these make up 2 different classes of drugs. These treat cognition and function of an individual, but there's no evidence that they're stopping or slowing the underlying progression of the disease. These have been around for a number of years by individuals. Some people benefit from them or see a benefit, report a benefit, others do not. And there's a number of reasons that an individual may or may not choose to take those medications, and that's certainly a discussion that they should have with their clinician. And those are approved really for individuals that have Alzheimer's dementia. The next class of drugs are those that are really treating symptoms. So we know around 85% of individuals with Alzheimer's dementia experience what we call the non-cognitive symptoms, so agitation, apathy, sleep disturbances, and some of those challenges. And so there is some work that's going on in pharmaceutical as well as non-pharmaceutical interventions for individuals in that space. And so the two that are in kind of the cyan color or the greenish color are really treating the mood or behavior, and those are more recently approved by the Food and Drug Administration, treating agitation and sleep disturbances for individuals. And then the last class of medication, which has probably been the most in the news in the last couple of years, are the three that are in purple, although the first one is no longer available. So only the 2023 and 2024 medications are available. And those are targeting the underlying biology of the disease with demonstration of slowing cognitive decline or clinical decline in the trials that they were conducted in. And so those medications really are our firsts as a field. They're our firsts that are targeting the underlying biology of the disease. They aren't right for everybody. They have side effects. There's certainly a risk-benefit discussion that needs to happen with the clinician and the individual based on what's right for the individual. And they are really for individuals that have mild cognitive impairment due to Alzheimer's or mild dementia. There are I know a number of groups here in New York that are actively have treatment clinics and are going for that. And within that landscape, there is really a specific medical monitoring and process that needs to happen. So again, really important as a consumer to ask those questions of your clinician in terms of the expertise and the setup that they may have within their clinical office. So while we have these medications in terms of the newly approved FDA medications making up this last class, these are our firsts. This is just the beginning. This is just the tipping point of where we as a field are. And I think you heard that a little bit from Dr. DeLeon. We really, as we've seen the increased investments, both from the Alzheimer's Association at the federal level, but also internationally, we have a greater understanding of the underlying biology. And it's really with that understanding that we really see this incredible landscape of what's being investigated in research and what's moving into clinical trials. So whether, amyloid beta and tau are two of the hallmark brain changes that we see in disease, but neural inflammation, the immune system, changes in the immune system, and those seem to differ at the earlier stages of disease or the earlier stages of brain changes throughout the more severe or advanced stages of disease. The vascular stress and vascular contributions to disease throughout the progression. Oxidative stress, the bioenergetics, how the brain cells are making and producing energy is also playing a role. And there's so much more. This is just a cartoon to really demonstrate some of that underlying biology, excuse me, that we know is present in the brains of individuals. And it's really with understanding that biology, allowing us to measure it using those tools like biomarkers, that we can start to think about combination approaches for individuals. What might be your biology or your specific changes may not necessarily be the same things in another individual. We don't know that because we're still understanding a lot about these tools and these biologies. But today, there are over 120 unique therapies that are in clinical trials for Alzheimer's disease. There are over 160 clinical trials that are registered for Alzheimer's. Now, this is as of April of 2024, so this is an annual review, so we'll expect a new one in the coming months to see how that landscape has changed. 33 new agents between 23 and 24 entered into clinical trials, so these were new targets, new approaches in terms of treatment. We have, in terms of, if you look over on the right side in the graphs, 75% of what's in clinical trials are novel disease processes. So thinking about, as we've increased our understanding of the biology, we're now seeing that translate into clinical trials. And I know I was speaking to a gentleman earlier who's one of those approaches, looking at how can we target ApoE, and specifically ApoE4, which is a gene known to be associated with increased risk, as a potential therapeutic strategy. And can you adjust the expression and the specifics of that gene in individuals? And so that's some work that started here in Cornell and is now in clinical trials today. But you also see that it's not just one kind of trial. So there's a number of things that are looking at, can we target the underlying disease? Can we benefit an individual's memory, depending on where they might be in the disease? And then some of those that are those non-cognitive symptoms that we talked a little bit about. So I want to give you an example that one is we get asked about a lot. So I've now just taken the approach of putting it out there proactively because it is something that people are asking about a lot if they've read headlines. And I know there was a headline not too long ago in maybe New York Magazine or some New York media. And so there are 2 ongoing phase 3 trials that are testing semaglutide, or Ozempic, as many people know it to be. Now, this is based on data that when they looked at the original trials from these medications that were done for other purposes and other reasons, and they followed those individuals. They pulled all of those trials together, and they followed those individuals for over 5 years. They actually found that there was a lower number of individuals that had dementia that received these medications compared to the placebo group, those that did not receive from the trials. And it was with that data, as well as some other supporting data, that the company launched 2 phase 3 trials to test semaglutide in an Alzheimer's population. So this is in the Evoke and Evoke Plus trial. There are 40 countries that are participating in this trial. It's an oral medication that is being delivered. There's over 1,800 individuals. 80% are MCI, 20% are early Alzheimer's disease, ages 55 to 85. They did require confirmation of beta amyloid in the brains of the individuals that they enrolled. And they actually also allowed individuals that were on stable monoclonal antibody to beta amyloid, so one of those medications that targets the underlying biology. They will report out in Q4 of this year, and this may be some of the first data that we see on a combination trial that has a small population of people, both targeting beta amyloid and then this other mechanism with semaglutide. Now, we don't know what the trial is going to show, so it's certainly something that is being watched in our field and in our space, and as I said, is something that I get asked about a lot, so I thought I would just proactively put it in here as an example of some of the work that's in the late stage development in our space. But as we think about this, and as we think about the point of today is the forum on prevention. So understanding all of the biology, we've been able to move a little bit back in time more and more. So we now have treatments that are for individuals in that earlier stage. Ultimately, how do we go even earlier? And again, that comes to understanding the biology is so fundamentally important, and is really why more than 50% of the Alzheimer's Association's funded portfolio is in understanding that fundamental biology. Because without that, we don't necessarily understand all the changes that an individual is experiencing. And as we think about this, can we move even further back in time as we go? Now, part of that is who should be in those trials, who might be at increased risk, who might have those brain changes as we go. And so can we even go earlier than that? Can we actually change the trajectory for individuals? And so there's a lot of trials that are going on that are actually enrolling individuals at this stage that have no apparent cognitive impairment, but have the brain changes associated with Alzheimer's. Trailblazer 2 and the AHEAD trial are 2 examples, but there are many others as well. But that's just a landscape of what's happening on the pharmaceutical side. There's a ton of work that's also happening in terms of behavioral interventions, and how do we think about that? What can we change either in risk reduction or throughout the underlying or throughout the disease progression for an individual? There's some data to suggest that no matter when you have cognitive impairment, there's a benefit to physical exercise, to getting a good sleep, balanced nutrition, and some of those activities as well. But what's that thing that if you had a parent or you had a sibling that had Alzheimer's or another dementia that you can do? Now we can give you the 10 healthy tips for your brain health. So good night's sleep and eat a balanced diet. Don't smoke. If you smoke, try to quit or reduce it. Exercise, physical exercise, continue lifelong learning. All of those are examples of behaviors that have shown a benefit for individuals and that may be able to reduce your risk. But what's that specific recipe? We don't have that answer today. But that's really why the Alzheimer's Association launched the US Pointer Trial, really taking the best information we have of science to target multiple risk factors at the same time in an at-risk population. So this is not a population of people that have cognitive impairment. This is not a population of people that we looked at their underlying biology. This is an at-risk population. This was done in 5 sites across the country, over 2,000 individuals, 2 different interventions, self-guided and structured, a 2-year intervention in the trial. Now, participants were aged 60 to 79 with no clear measurement of cognition, so no objective cognitive impairment, but were at an increased risk for cognitive decline. So again, they were randomized between the 2 intervention teams and the multi-domain intervention. So this was targeting multiple or simultaneously targeting multiple risk factors at the same time, including physical activity, nutrition, cognitive exercise, medical monitoring, and a social component as well, in a very specific, measurable recipe. And looking at how do we then objectively collect the information and measure both the intervention component, so their dose of each component of that, and then look at the outcome based on cognition. So I don't have the answer yet to the trial, but it is going to be reporting out this summer at the Alzheimer's Association's International Conference. So this is something that we are anxiously awaiting in terms of what this tells us and how this can inform what kind of recommendations we could potentially make. This study is one of the more representative studies in our space, with about 31% from historically not included populations within this clinical trial and within this study. All of the baseline data has been shared, and the study data will also be shared, as this is funded fully by the Alzheimer's Association. There is additional funding from the National Institute on Aging that added in imaging, some vascular measurements, microbiome, so looking at the gut health, and some other things as well that will also be shared with the research community. And so thinking about not only answering that primary question, but also saying, what's the impact of the intervention on the biology? What changes? What can we impact? So as we then start to think about the personalized approaches, you have a combination not just of medication, but medication lifestyle, medication behavior, and who's going to be most responsive to those interventions. Because at the end of the day, as we understand Alzheimer's disease or any of these diseases that cause dementia, there are so many brain changes that are happening. It's not only one thing. And it's these changes that we need to be able to measure with tools, whether it be the fluids or imaging or some of these emerging tools, and then intervene with interventions, whether that be medications or whether that be lifestyle and behavioral factors as well. And it's that combination approach that we'll continue to take forward as a field and as a community. And that's why, to the researchers in the audience, at every point where you're touching in your research, and I know there's a vast array of individuals that are working on a number of different things in this audience, at every point in the work that you're doing, you are touching somewhere in this space that's moving us forward to help the individuals that are affected by Alzheimer's and all the other diseases that cause dementia. So in summary, this is an incredibly exciting time, and we're going to hear from 3 researchers that are going to talk in greater detail about vascular dementia, some of the tools on imaging, and some of the underlying biology in greater details for in Alzheimer's and how that applies. And thinking about this in that umbrella, about how this applies to our understanding of the disease, how that's going to translate to the tools for diagnosis, and how that's going to translate to new treatments and new interventions as we go forward. So with that, thank you so much for your time and your attention, and I'm really looking forward to our next 3 speakers.
Thank you so much, Dr. Snyder, for really setting the stage. I think that's such an important foundational shared knowledge we all have going into these next 3 presentations. And I think it was also great to hear you signaling the places where we're going to get to hear a little bit deeper from our next 3 speakers. So with that, I want to highlight to everyone that the full bios of our esteemed speakers are on the back of your agendas, because we really want to focus our time today on hearing from them and hearing about the work. So for the next 45 minutes, you're going to hear 15 minutes from each of our 3 different speakers. First, we'll have the honor of hearing from Dr. Matthew Fink, and he's going to speak on the topic of vascular dementia. Then we will hear from Dr. Lydia Glodzik around imaging and the influence of vascular risk on the aging brain. And finally, we will welcome Dr. Lee Gan to the podium to talk to us about inflammation and demyelinization in Alzheimer's disease. So we're going to get you loaded up. Oh, excellent. Dr. Fink, the floor is yours.
Thank you so much. I'm delighted to be here, and I want to thank all of you for joining us. I'd like to thank the organizers of the program, Michelle Greco, along with Sonia Bloom and Gloria Chang, really put in a lot of hard work and effort to make this happen. And we really appreciate it, and we're delighted to be collaborating and working with the Alzheimer's Association. Let me tell you just a little bit about myself. I'm a general neurologist. I've spent my career developing programs and new treatments for patients with a whole variety of different disorders, not patients who had cognitive impairment. And about 5 years ago, I made a pivot in the middle of the coronavirus pandemic in New York City for the simple reason that the need was so great to help patients. The numbers of patients coming to us became so large that I just sort of decided to just jump into the whole fray and do what I could to help out. And that's how I really became involved in this. So I wanted you to understand where I fit into this. I'm not someone who spent my whole life studying and developing research in Alzheimer's disease, not at all. But I'm going to talk about vascular dementia because I did spend a lot of time taking care of patients with stroke and developing new treatments for stroke. And so we're going to talk about that. I have some disclosures to make that have nothing to do with money. The first disclosure is that a lot of the comments I make are going to be controversial. And in my view, academic medicine needs to be controversial. If we don't ask hard questions about things, we're never going to get the right answers. So I'm going to say some controversial things. I hope people don't get upset about it. And then I want to give special thanks to Dr. Idakola. Costantino Idakola has been working in his lab here at Weill Cornell for 30 years, studying the mechanisms of how cardiovascular disease affects the brain. And his research taught me a great deal over the years. And he's not here, I don't think. I guess he's traveling or something. But I just want to acknowledge the fact that his work has really been pivotal for what many of us are doing within this field. So here's one of my heroes. I.M. Pei, most of you must know him, a wonderful, brilliant, creative architect who died at the age of 102 a few years ago in excellent health. He was working in his office the day he died. He went home, he wasn't sick, he went to sleep, he didn't wake up, and that was it. Wouldn't that be a great way for all of us to end our lives? And so why is it that, you know, he got to go to age 102 and be in such good health and have a well-functioning brain? Well, most people are not that lucky. And if you look at the actual data and statistics of what's going on, look at the 4 leading causes of death: heart disease, stroke, lung cancer, Alzheimer, and other dementias. So the field of neurology plays a large role in this, a large role. And we need to really look at this as to why it's like this and what we can do to change it. And one of the issues is that the primary risk factor for dementia and stroke is age. Age. And we're all getting older, and the proportion of the population is getting older. A larger proportion of the population is getting older, which is why I sort of jumped into this, because we have so many patients that need our help and need some help and treatment. So we have to focus on that because none of us really can slow down the aging process. So this is a big issue that we have to deal with. Now, how do patients, I'm going to show you 2 patients that I recently saw literally in the last few weeks in the office that demonstrate one of the big problems we're dealing with. And one of those problems is there has been such a major focus on making a diagnosis of Alzheimer's disease that in some ways physicians have forgotten about all of the other causes of dementia. And I want you to think about that, and I'm going to use these cases as an example of that. This is an 87-year-old man with cognitive impairment. He would have, by our definition, mild cognitive impairment. He lives independently, takes care of his ailing wife, had memory loss, but he also had poor balance, trouble walking. He saw 2 cognitive neurologists. 2 cognitive neurologists. They put him through the huge battery of tests, everything that you discussed, Heather, to evaluate him. He was scheduled for amyloid PET scan. And he said, before I go for an amyloid PET scan, let me get another opinion. And we saw him. And what we discovered that seemed to have been neglected in his evaluation and history is this long list of really significant and serious cardiovascular problems. aortic stenosis, valve replacement, atrial fibrillation, heart failure, hyperlipidemia. He had a cardiac pacemaker, on and on and on. And when I looked at his brain MRI, which is here, this is only the left hemisphere. He had extensive white matter hyperintensities around the ventricles in both hemispheres. What I don't have up here is a picture of his brain stem. He has some white matter hyperintensities in his brain stem, almost certainly small little infarcts. And he has microvascular ischemic disease in the brain, which in my view explains a great deal of what's going on with this man. And the other thing is, he has atrial fibrillation as being treated with antithrombotic medications, which puts him at a very high risk for treatment if he was going to be treated with one of the anti-amyloid medications. Yet, both cognitive neurologists at major medical centers were pushing ahead. We think you have Alzheimer's disease. Let's get the testing done, get you started on treatment. So that's the first example. Another patient. Again, just saw these people. 81-year-old woman with short-term memory loss, lives independently, loses her way while driving, needs reminders for events and appointments. She had a full neuropsychological test, saw a neurologist in New Jersey, came here for another opinion. These are her MRI scans. And again, pretty profound. This is really quite remarkable. Large areas of parietal lobe atrophy, frontal lobe atrophy, and then look at all of the white matter changes that she had on her MRI. She was referred and told, you probably have Alzheimer's disease, and you have to think about treatment. Well, another piece of information completely neglected by the doctors who saw her was this. In 2007, she was treated for breast cancer and angiocarcinoma and had 2 chemotherapeutic drugs which have very significant neurotoxicity. Very significant neurotoxicity. I reviewed this with her oncologist, and in fact, her white matter disease is almost certainly related to the neurotoxicity of the chemotherapy she got. So, 2 examples of patients seen by experienced neurologists, some cognitive neurologists said, we think you have Alzheimer's disease, let's get your workup done quickly so we can go ahead and get you started on treatment with medications. So my wish for all of us is that we evaluate all patients who present with cognitive impairment and dementia carefully, thoroughly, thoughtfully, and not just assume that everybody who comes in has Alzheimer's disease. That's really something we really have to think about. So how do these patients come to us? Well, most of them come in with, complaining of short-term memory loss. Where did I leave those keys? I have been losing my keys my entire life. I solved that problem, by the way. Okay? I solved the problem. I clip my keys to my belt and I don't lose them anymore. And I don't worry about this anymore. But so many patients come in and that's what they're complaining about. And they think they have Alzheimer's disease because they have this one slight short-term memory problem. So what do we learn about this? Well, there have been very good long-term longitudinal studies looking at episodic memory and executive function in healthy people. And there's a slight decline that occurs starting in the mid-30s and continues on. These are people who were never diagnosed with cognitive impairment or dementia. They were followed for a long period of time. So isolated short-term memory impairment, like I can't find my keys, I'm forgetting people's names. The other thing for me is I couldn't remember a telephone number to save my life. Thank God cell phones were invented. So that doesn't mean you have dementia. So we've got to be really, really careful about this. So we're talking about cognitive impairment, and cognition is much more than just isolated short-term memory. It includes attention span, ability to think through problems, understanding language, learning new materials. Yes, memory, solving problems, making decisions. And yes, some of these things decline as we get older, but some of them actually get better. what do you think gets better with age? Well, we actually get better solving problems and making decisions as we get older, even if our short-term memory is impaired. So some things actually get better, not everything gets worse. And then what's dementia? We talked about this earlier. Dr. Snyder was very, very clear about this. Dementia means that you have impairment of several cognitive domains that interfere with your ability to manage your daily activities. That's really the hallmark of it. And in my experience, neurocognitive testing is less useful in determining that than sitting and talking to the family members and taking a careful history of how the person is functioning in life on a daily basis. And this is a slide that is from the Alzheimer's Association. Heather showed you the same thing. I modified it a little bit because, again, I'm going to make the argument that the association puts these numbers in. 60 to 80% of patients with dementia have Alzheimer's disease, 10 to 15% have vascular disease. So I think the Alzheimer's number is too high, the vascular number is too low. And in fact, I'm going to make the argument that most patients with dementia have mixed forms. And there's a dominant pathology of one sort or another and co-pathologies. And we really have to grapple with that. So we can't just say, oh, you have Alzheimer's disease, let's treat you with this drug and forget about the vascular pathology, forget about the Lewy body pathology, because all those things are going to be present and we have to take them into account. So these are my numbers as best that I can come up with for review of the literature. I think 50% of people have predominantly Alzheimer's pathology, 25% have vascular disease. Most patients have mixed forms. And I just put one study up here, the UK Brain Bank study from 2021. There are a number of them that have looked at the same thing. Of patients that were diagnosed with dementia, 65% have mixtures of Alzheimer's and vascular pathology, and 50% have mixtures of Lewy body pathology. So we're really dealing with a complex group of patients, not to scare everybody, but let's be realistic about what we're dealing with. Let's not try to narrow it down and say, you only have Alzheimer's disease, you only have vascular disease when we're dealing with mixed pathologies. Now, vascular dementia was described actually initially by Otto Binswanger, who was a collaborator with Alzheimer. He described this first case in 1894. And it was really forgotten for years and sort of rediscovered by some of the stroke neurologists, C. Miller Fisher, Vladimir Hachinsky, who started writing about this in the 1960s. But it has largely been ignored even by neurologists. I took a quick break, went upstairs, and one of my faculty members who's been here a long time asked me what I was doing. I told him I was giving a talk about vascular dementia. He said to me, "Oh, is there really such a thing?" That's what an experienced neurologist said to me an hour ago. So we've got a big problem. We've got a big problem with this. So the NINDS has diagnostic clinical features that they grew out of a symposium that they held in 1993. And it starts with, number one, the person has to have dementia. That's the start. So if you have a person with dementia who then has a number of these other associated symptoms, gait disorder, urinary problems, focal or sensory signs on exam, or severe mood disturbances, you have to look for something else. Patients who present with what we think is predominantly Alzheimer pathology early on, they don't have any of this stuff. They don't have this. They have a pure syndrome of cognitive impairment. They don't have all these motor findings and all these other things. When we see that, it's a red flag that something else is going on. And then if you're talking about just mild cognitive impairment alone, not dementia, there is no typical clinical presentation that separates Alzheimer's dementia or Alzheimer's disease from vascular disease. There is none. The patients can look exactly the same. They score the same way on neurocognitive testing. So you can't really be sure about it. So let's talk about the blood supply to the brain and how that can end up causing patients to have cognitive impairment. All right, this is a simple diagram. The heart pumps the blood up the carotid vertebral arteries, and these are the large vessels that supply blood to the brain. You don't need to know more than that. This is not the cause of vascular dementia that we're talking about. This is the cause of patients who have strokes. And yes, a stroke can cause cognitive impairment, but that's a pretty obvious thing to us. So what are we talking about when we talk about blood vessels in the brain? This is a diagram from Dr. Ida Kola showing what's called the neurovascular unit. This structure, which you see on the screen, in the brain is about a 0.5 millimeter in diameter. It's tiny. You can't see it except under a microscope. And this is what regulates blood supply going through the brain. Under normal circumstances, it's regulated by synaptic activity. As synaptic activity and demand goes up, these vessels open up a little bit and blood flow increases. You can measure it with a fMRI. If blood pressure exceeds a threshold, it causes these little vessels to open up and you get too much blood flow, which results in leakage of fluid into the brain. You get cerebral edema, or worse, it can rupture and you end up with a hemorrhage in the brain. So how does that look in pathology? All of these pathologies, I'm not going to go through them one at a time, all of these different pathologies result in small vessel disease in multiple parts of the brain, multiple small areas of ischemic lesions, of infarcts. And they can occur in white matter, they can occur in gray matter. It depends on the underlying cause and the vascular distribution. So as you heard earlier, it isn't one disease which is causing this. This is hypertension, amyloid angiopathy, inflammation, granulomatous inflammation. A whole variety of disorders can cause this pathology, and we have to look for those. We can't just make a global diagnosis, but we have to look for them. So let's talk about high blood pressure, which is probably the most common cause for this disorder. Here's a diagram of the brain, and these are the MRIs above. What do we see in patients that have chronic hypertension? They get multiple small multiple small microbleeds in the brain, which before MRI was available, we could not see these things on CT scans. Then you've got multiple white matter ischemic lesions. You can get hemorrhages. And then if there's leakage around these little vessels, you get enlarged perivascular spaces, which are often misinterpreted as small infarcts. So you've got multifocal small lesions in the white matter that cause the problem, that cause the impairment. This is just another example, small little lacunar infarcts. When they accumulate, the patients end up developing cognitive impairment. I'm going to jump ahead quickly. So both large vessel disease, which can cause strokes, small vessel disease, which can cause multiple small hemorrhages or multiple small infarcts throughout the brain, cause cognitive impairment. It could be mild cognitive impairment. It can be dementia, depending on how severe it is and the amount of brain that is affected by it. And then when we talk about heart disease, atrial fibrillation is a particularly troublesome area. It's one of the most common cardiac disorders. It accounts for 25% of strokes, but even without having a stroke related to atrial fibrillation, the risk of developing dementia is much increased in patients that have chronic atrial fibrillation, even without stroke. And we don't know why that is, not fully understood. So risk factors for dementia are often modifiable. They're lifestyle factors listed over here. They're physiological factors which can be treated. And the most interesting part is if you look at what's connected to vascular dementia or what's connected to Alzheimer's disease, there's a tremendous amount of overlap. A lot of modification of lifestyle factors reduces the risk of getting what we're diagnosing as Alzheimer's disease. And that gives us a great opportunity to change things. And how do we change things? Well, I like to keep things simple, particularly when I'm dealing with patients. You get too complicated, the patients don't know what to do. So the American Heart Association, based on good epidemiological research, came up with what they call the Essential 8. These are 8 modifiable risk factors for cardiovascular disease, which, if started as early in life as possible, and I would say, anybody who hits the age of 40 should really start paying attention to this. If you can start it earlier, it's even better. But healthy diet, regular exercise, monitoring blood sugar, ideal body weight, lower lipids, normal blood sugar, stop smoking, good sleep. 8 items, all possible if you work at it. And if you do this, you will reduce your risk of getting dementia. You will reduce your risk of getting a heart attack. You will reduce your risk of having a stroke. This is like the perfect trifecta. And this isn't even getting into trying to treat underlying diseases or having your doctor put you on medications. This is something that we can all do ourselves. And the goal is to get to this place. These are 3 of my favorite rockers who are still going strong, in their 80s. They're touring and they're playing, and this is what we should aspire to. So thank you all for listening.
Thank you, Dr. Fink. And if you have questions related to that, I want to encourage you again to write them on your index cards. And for those of you in the audience, I know I see a few of our community educators and others who have been to programs. You just heard about 8 factors from the AHA here at the Alzheimer's Association, and Dr. Snyder referenced it as well. We talk about 10 healthy habits for a healthy brain. So there is a ton of crossover in what we all know about things that we can do to keep our brains healthy. And with that, I am happy to introduce our next speaker, Dr. Lydia Glodzik. We're going to get your slides up right here. And she's going to speak. We had this reference a little bit earlier about imaging the influence of vascular risk on the aging brain.
Thank you all for being here. And first, my heartfelt thanks to Alzheimer Association and to my colleagues and Weill Cornell for giving me the opportunity to showcase a part of the work which my colleague and I are doing at Brain Health Imaging Institute. I am so happy that I'm talking after Dr. Fink, because without planning, I think we synced perfectly. And I am not sure whether my title is misleading, because actually my talk will be heavily focused on hypertension. First, I will talk a little, why is it a risk for Alzheimer's disease? I will give you a snapshot of our study, so it's very narrow window into brain through imaging, brain with hypertension. Finally, it's somewhat not related, it's somewhat different topic. I will talk about white matter lesion, expanding a little bit of what Dr. Fink talked about, and some alternative possibilities related to their mechanisms beyond what those related to vascular. Let's start with, why is hypertension a risk factor for Alzheimer's disease? After my predecessor, I don't need to talk much about the fact that it is definitely affecting large and small vessels. It's believed that small artery changes are actually one of the earliest lesions which are the sign of organ damage in hypertension. I think I like to partition the reality, and this is how I would like to present it to you. Why is hypertension affecting brain? I see it in at least 3 pathways. It starts all with the fact that we have vessels which are not functioning well. We have deficiency in circulation. The blood supply is not perfect. What I focused for years was thinking that it creates energy crisis. We have ischemia, we have oxidative stress, we have inflammation. And I was truly thinking that this was the pathway which can activate the pathways which are known as specific to Alzheimer, like those leading to amyloid accumulation and to tau deposition. And we did some work on this. However, I will focus on something else today. The other pathways are reductions in clearance, and thus possible accumulation of tau and amyloid through this pathway, or which Dr. Fink talked about, they just simply cause damage to the tissue. Thus, the brain reserve is diminished, and through infarctions, hemorrhages, and the changes related to small vessel disease, such as white matter lesions, microinfarct in large periventricular spaces, they synergistically contribute to symptoms of dementia. So, is it true that hypertension is really related? Let's just stop for a moment and look through pathology. Meaning, is hypertension related to what we see in the field as hallmark of Alzheimer's disease, amyloid and tau? This is a meta-analysis of many post-mortem studies, quite a few thousand people. And indeed, it showed that having hypertension anytime during lifetime was related to not very significant, to not very highly, yet significantly increased chance of having more tangles and plaques in the brain. What do we know from studies, epidemiological studies? There is no question that hypertension in midlife, what is it, in our 40s and 50s, indeed increases the dementia and Alzheimer's disease later in life. This meta-analysis was 24,000 people. I don't know if it's really 18%, but let's just say 20 for people who had pressure in the ranges over 140, and for those who had even higher blood pressure when they were in their 40s and 50s, this risk increased even more. I think here the mean follow-up was about 13 years. The longest follow-up in the studies analyzed here were over almost 22 years, and the people started here. I think the mean age of they were like around 55. No question about hypertension in midlife. What's happening when we are in our 60s or 70s? Here the evidence is much less, I would say much more nuanced. It's not that clear whether having is it not that clear whether having hypertension is really related to dementia. Some studies are showing that it is. Some studies are even showing that higher blood pressure is somewhat protective. Some show no association. Again, a huge meta-analysis of studies on relation between hypertension in late life and future dementia showed that people who have untreated history of untreated hypertension still have increased risk later. Later was about 4 years from the baseline. However, there was no association truly between what kind of blood pressure they have when they were examined at baseline and future risk of dementia. I find it fascinating, and why is it so? I think one of my favorite explanation is that when we are getting older and our vascular system is somewhat damaged, it is not clear whether low or high is a risk or is a protective factor. Let me I think that was one of the reasons why we did the study quite a few years ago, looking at perfusion. Looking at perfusion in our group of almost 500 healthy individuals. And we looked how perfusion, how having high blood pressure affects cerebral blood flow. I will talk a little bit about imaging studies which we routinely are doing. Here there are quite a standard imaging, T1, FLAIR, when we can see white matter lesion, susceptibility weighted images, when we can see microhemorrhages, other lesions as well, which I will talk about later, and of course perfusion, which we were doing with arterial spin labeling. So there will be few slides about this part of the graph showing that indeed hypertension is related to CBF reduction. Again, when we looked at all our group as a total, 450 cognitively healthy people, some with hypertension, some without hypertension. No question that in general, when we look at them all, the lower the pressure, the better the perfusion. However, it wasn't that clear for people with hypertension. Actually, there was an inverted U-shaped relationship, especially for the hippocampus, when we saw that people, to some degree, when the pressure was too low, actually the perfusion was not that great. And there was a point of optimal blood pressure at which the perfusion was the highest. I think it perfectly ties to this finding that in the 70s, 60s, there was no clear relationship between the level of blood pressure and future dementia, because I would say in general population, there is a linear relationship. The higher the blood pressure, the lower the perfusion. So, however, in certain conditions, when the vascular system is damaged, vessels may not be very well, able to properly respond to changing perfusion pressure, and even somewhat lowering blood pressure may lead to relative hypoperfusion. Now the question is, why would treating the treated blood pressure would be related to lower risk of dementia? One of the possible explanation is that also blood pressure medications have other pleiotropic effects beyond those related to simply lowering blood pressure. We follow up this study with the study of white matter lesions. I wanted to show you a little about how hypertension affects accumulation of white matter lesions. I think after Dr. Fink, I will not elaborate. Those are just different, for those of you who are not very familiar with imaging, those are very simplistic images of showing different levels of almost no, a little bit of periventricular, and deep white matter lesions, a little bit more lesions, and here more pronounced deep white matter lesions. Again, a similar group of people are cognitively healthy, about half of them with hypertension. In general, there is a significant, although not a strong relationship linear between blood pressure and white matter lesions. The higher the blood pressure, the bigger the white matter lesion volume. However, again, in subjects with hypertension, there seems to be an optimal point, optimal window of blood pressure where the chance of having white matter, the volume of white matter lesions is the lowest. For both of this study, for our group, it was about 125-26, which I was very happy to see that for both, that they were consistent. Again, as with perfusion, we would need to conclude that although in general, higher blood pressure is related to more lesions, there might be a condition, like for somebody who had long-standing hypertension and already atherosclerotic changes in vessels, where actually drop in pressure may lead to drop in perfusion, tissue damage, and white matter lesions. Let me move a little towards clearance. Why hypertension might affect clearance? The issue of clearance became a very hot issue in the Alzheimer field for about last 15-12 years. Okay. I will start with this very simple diagram of so-called lymphatic system. So looking for different causes, as Dr. Snyder has mentioned, of why there is accumulation of amyloid in tau in the brain. One of the hypotheses put forward is that the clearing of the brain is not good. And it was postulated that the clearing occurs along perivascular channels, along arteries, then the fluid travels through the brain parenchyma and gets cleared through on the venous side. Naturally, you would think that this whole system is predicated, good functioning of the system is predicated of a health of the vascular system. Thus, our question was, is having hypertension affecting brain clearance? In short, we started the study almost 5 years ago. We are really finishing our last assessments. I will have to say our answer for now is yes. We were using a method invented in our lab by Dr. De Leon and my colleague, Dr. Lee. So you would have to ask me, is this possible to measure indirectly in human? Not really. However, we used a method based on PET imaging when we were using the measurement of how fast the tracer was removed from the ventricle. We are not claiming that it is by anyhow a clear measurement of what is happening in the lymphatic system. However, by using this method, we were able to compare people with and without hypertension and prove that for now we have a significant, although small, difference in the clearance of the brain as such that people with hypertension indeed have smaller clearance, which once again proves that it might be an important contributor to hypertension. I'm very happy to answer any questions later on, and I think I'm going to stop right here.
Okay, thank you so much. And yes, I think that even for me as an audience, seeing the connections of the images between so much of what we're talking about is really insightful. So if questions are coming up, please write them down. And let's get our next speaker ready. Dr. Gann, the floor is yours. Thank you.
All right. I'm very glad to be here and also to follow three fantastic speakers. So I don't have to give a lot of background. So I will dive into the biology that we've been working on for Alzheimer's disease. And I do want to show this slide to emphasize that our brain are highly resilient. So I think the topic of today is about prevention. I think with our resilient brain, we're in a very good company that, as Dr. Snyder has shown, that amyloid deposition occur 15 to 20 years before any symptom occurs. So that means our brain actually are highly resilient against amyloid deposition. We can live with amyloid deposition, and I think I probably have amyloid deposition already, given my age. But so far, I feel I'm cognitively normal. So there is a really good window to work with to prevent the cognitive decline. And how do we boost that? What if we lengthen the period from amyloid deposition to cognitive decline by 10 more years, by 20 more years? And that would solve actually most of the problem, because most of us are not going to live till 100. So if we can lengthen the period from A beta deposition or some of the biomarkers to to when any cognitive decline occurs for 30 years, problem solved, right? Can we do that? How can we do that? So the research in my laboratory is focusing on these two aspects. One is the inflammation, which occurs a little later. Another is tau-induced injury. In particular, I'm going to talk about demyelination. So these are the two areas that we think we could have a chance to boost the resilience. What is a chronic inflammation? What is brain inflammation? So I use this as an analogy. This shows the joint inflammation. So when you have rheumatoid arthritis, you have this joint to have this inflamed. Brain can also have this chronic simmering inflammation. And this is because this is unsuccessful attempt for the brain to return to its normal state. And because of that, they cannot do it. The reason they cannot do it is because the triggers for this inflammation are persistent. You heard about vascular damages. You heard about, of course, amyloid and tau, and also mixed pathology, Lewy body. All of that are persistent in the brain, and that leads to persistent inflammation. And what are the cells in the brain that are responsible for, responding to this accumulating pathogens? The main immune cells are microglia. So microglia are built to guard our brain. So they are the immune cells trying to return the brain to the normal state. And that's why they're highly motile. They actually converge on any damages or any debris that it can detect. So this is an in vivo imaging that seen through the skull, and the microglia here are labeled with EGFP. So you can see the process that converging on this injury site that is caused by a very high power laser. And microglia's role is adaptive, is responding to the injury, and their responsibilities are like firefighters or policemen all in one, trying to clear the aggregates, clear the debris, and fight the fire, right? And also can participate in tissue repair, and can also promote neuronal repair with this trophic effect. But in the neurodegenerative, in the Alzheimer brain, the microglia can no longer do that because of this persistent triggers that leads to excessive responding to this, and that have biological consequences, including excessive complement that leads to synaptic pooling. Synapses are the structure that neurons talking to each other, and also excessive cytokines, that is the trigger of inflammation. So why we think microglia and immune response are important? And this comes from human genetics. So this is a Manhattan plot showing the genes that can increase someone's risk to develop Alzheimer's disease. So these two genes, TRIM2 and ApoE4, these are the genes that when people carry the mutation on this gene or carry ApoE4, as you heard from Dr. Snyder and others, the most predominant risk factor, this shows that they have a higher chance to develop AD. And all of those genes, both of the genes, affect our immune cells to respond to injury. So in this study, a former graduate student in the lab has led to show that if we have mice that carry these two risk genes, in the presence of the tau pathology, which is one of the major hallmarks of AD, then we have persistent microglia induced injury. And that shows with a hyperactive antiviral response called C-gastin. And this hyperactive C-gastin can be triggered by excessive mitochondrial DNA release, as well as nuclear DNA damage. And when she inhibited the mitochondrial DNA release with VAX inhibitor or with C-gas inhibitor, the microglia senescence injury is rescued. So this is what I meant. What the pathway we're talking about here is triggered by C-gas activation and trigger the STING activation going from the ER to the Golgi, and leads to activation of a pathway called interferon. And this interferon pathway is nature's way to fight against viral infection. But in this case, even though there's no viral infection, the system detected something is wrong, so they activate this interferon pathway, and that leads to actually tissue damage. And as shown here, so this shows that interferon genes we use a single cell RNA-seq analysis, allow us to look into individual cells, these are individual microglia that carry the AD risk. They have much higher level with a darker brown color of interferon signatures. And what is the consequence? The consequence is much worsened neurodegeneration. So this is a brain, and this is normal brain. And you can see the brain that carry these two risk genes have a much larger ventricle. And that's because there are much more neurons that lost, leaving a larger ventricle. Can we do something about it? So in this study we published 2 years ago, we found that if we inhibit the pathway, either genetically or using small molecule inhibitor, we could actually reverse that. We can enhance brain's resilience against the pathology. And so details is not important here, just to show that in both behavior studies as well as synaptic plasticity analysis, we find that inhibitor are able to protect against the injury that's shown here. It was also able to protect against the synaptic loss, which is a structure that's responsible for neuron-neuron communication. With the inhibitor, we were also able to protect that. So let me move into another way neurons communicate, and that is through this large long axons that shows, this is a cross structure of the axon. And this structure, the neurons communicate with each other, is actually damaged in the ApoE4 human brain. And this ApoE4, as we know, is a major risk factor for Alzheimer's disease. And what does this structure do? So the structure is actually showing here. The neurons that have the axons have the structure, the signal, electric signal can travel 100-fold faster. So just imagine if this is lost, as showing here, this, we call it myelin sheath. When this is lost, the neurons' communication will be greatly hampered, right? So, and then you heard that in the human, this white matter hyperintensity, which is a measure of the white matter, which is this myelin sheath, the loss is correlated with the decline of the cognitive decline in the Alzheimer's brain. So is inflammation linked to the demyelination? So in this study that's published late last year by another former graduate student in the lab, we found a key factor, a toll-like receptor 7, is driving this Alzheimer-related demyelination. I'll just show you one data slide, and for this, but toll-7 is actually a very important gene that is linked to another immune disease called lupus. So what Chloe found is that there is a significant sex bias, like different vulnerability between male and females in the demyelination, which shows that males actually have a stronger demyelination. When then she treated the animals with the inhibitor for this receptor, she found the myelin, the loss of myelin in the hippocampus, which is a region responsible for memory, is completely protected. So with that, what I will argue is we're working very hard on trying to find mechanisms to target, to boost the resilience in both male and female brains. I showed you that we can use cGAS inhibitor to fight against the chronic inflammation. We can also use toll receptor 7 inhibitor to fight against demyelination. With that, I want to thank my brilliant team, showing here, some of them are here today. I'm very lucky to work with such a brilliant team and also the funding agencies. And also, I wanted to shout out that in this very room, our Appel Institute had the Thanksgiving party. I think this is the background. And we are working very well, a group of people that we are at Weill Cornell working very hard against neurodegeneration and Alzheimer's disease. So thank you.
Thank you so much. It's so exciting to hear. Today, we're just hearing some snapshots of work happening here at Cornell, but we know that exciting work is happening at institutions all around New York City, all around the country, and all around the world. And with that, we're going to have time for some questions. So I'm going to ask, I know Antonio's going to get us set up, but we're inviting our three speakers up to the front. Dr. Snyder, we actually have some questions that were already handed in on index cards. And our two co-planners, if they're still here, Dr. Bloom and Dr. Chang, if you want to join us, you're more than welcome to as well.
Lydia, Lee, you want to come up here? And I'm going to try to do the two between. We have a ton of questions. It's up to you. Do you want to move that way? Because I'm going to try to do the ones online too. So let me make those bigger. All right.
That works.
That works. Can you see them? All right. All right. So those on the Zoom, and we have a ton of questions on Zoom, and we have a lot of people on Zoom. I'm going to go back and forth between questions that have come in on the room and questions that are coming in on Zoom, and they just keep coming in on Zoom, starting at, kind of 15 minutes into the talks all the way through. So we have a lot of questions, and we'll get through as many as we can, and we'll try to bring some of the different questions together. And just for all the speakers, just make sure you use the mic to respond to questions. And I think we've got 2 mics to share among the group so that those on Zoom can hear us. So I'm gonna look at, and there's a couple questions that talk about some of the different medications or some of the different ways of treatment. And in particular, if you are at this point in time thinking about you have a concern and you're wanting to see a clinician, there's a number of questions that are saying they've been referred, there's a waiting list. What are the types of things that they can think about? And so maybe Dr. Fink and Dr. Bloom, I'll start with you all to maybe address that. What would you tell a family that is trying to see a neurologist, they're trying to see somebody in thinking about a diagnosis, they want to understand if there's maybe a treatment that's right, an intervention, what should they be doing, what are the things they should be thinking about for their loved one, but there's a 9-month waiting list. What would you tell them? And I will say, there's about 5 questions that are very similar. So this is something that I think, as I'll have them answer, and then I'll talk a little bit maybe about context.
Thank you for everybody's questions. And this is a tough one. So as we have learned more about the brain and about Alzheimer's, about the various causes of cognitive decline, especially now that we're able to move towards prevention, there's so much more interest and need, and so the field as a whole is still underprepared and kind of just a complete sort of revamping or just expanding our resources. So the wait times are long, and there's an ongoing conversation with primary care doctors, home medicine doctors, other doctors that are sort of at the forefront of seeing patients regularly. How can we best meet this need? So various ways to screen, and some of our also colleagues from across the city are coming up also with some new methodologies. I'm going to point the finger also here at Stephanie Casantino from Columbia, and their team has been working on developing some short screening tools, cognitive screening tools, to really help us without doing full neuropsychological testing. How can we have some screening tools for patients who come in concerned to be able to decipher who needs urgently to be seen, sort of triage a little bit, and also we're working obviously on also expanding our ability to accommodate more patients in the neurology, in the neurology.
I'm going to add something to this, just because that is how I got into this in the first place. Jumping in to try to help out because it was so difficult for patients to get to see anyone. So that's how I got involved in the beginning. So my suggestion is that you start with any of your physicians. It could be a primary care doctor, if you're an older person, you have a cardiologist, and those physicians can get the process started. They can actually do a lot of the basic diagnostic testing that needs to be done initially, blood work, brain imaging, MRIs, other things like that. So a lot of that can be done quickly by one of your other doctors. And then once that's done, it's going to be a lot quicker and easier to get an appointment with someone who's an expert. That's really what I would suggest. At the moment, there just are not enough neurologists or cognitive neurologists around to take care of all the patients that need help.
And maybe just kind of in thinking about some of the landscape of what we're seeing across the country, is there's a lot of work, and one of the questions I was just given, I'm going to just kind of put that into the answers. There's a lot of work that's going on to say, can we use tools and some of the technology like AI to actually identify within our medical records and within the system who might be more likely to have a cognitive complaint, and include that as a trigger within the medical visit. So regardless of the specialty, the physician or the clinician somebody is seeing, primary care, that's part of the conversation, allowing some of the tools like you just heard that are being developed across the country or around the world really, and bringing those into the clinic for some easy ways of saying who might be most likely to be experiencing memory concerns, and then getting them into the place that they need for care. And so there's a lot of work that's going on at a systems level to really build out these tools. This is new in our space. We're in a new era. And so it's incredibly frustrating for anybody that's right now and trying to get in the door. And we get that. But as a field, we're really looking at how can we, from a systems approach, address this and make sure that people are getting to where they need to go. The other thing I would tell you is that the Alzheimer's Association is in your community. You can reach out to the chapter to see if there is a resource or a place that they can help direct you in the meantime. So I would encourage you to think about that as well as, and I know there are some team that is here in the room. So thank you for that, because there was, like I said, there were several questions online and a number of questions with that came into here as well. A handful of questions, and I don't think we talked about this in great detail, but it was maybe touched on a little bit in the different conversations. Is someone interested in talking a little bit about gut health and the brain and thinking about that? It ties in, I know, to inflammation and some of the work that's going on with inflammation, and I know it certainly is a topic that comes up in the clinic as well. Do you want to touch on it?
I think the gut-brain axis has been, I mean, we call ourselves gut brain, right? So I think in a way, I think there's more biological evidence that gut health play a very important role for brain health. There are several evidence from the research perspective, and talking from the modeling perspective is some of the aggregates that could first occur in the gut, and it can actually be propagated to the brain. And also the gut health have a very big influence on the microglia states, which is a immune cell in the brain. So I think in a way it is a more accessible place to intervene. So if we can imagine that improve gut health to improve brain health, that creates a tremendous opportunity to for us to improve brain health. So it's a very active area of the research, and I think the amount of gut microbiome in the gut is just mind-boggling. You know, so there is a lot of need for big data, and a lot of tools need to be developed to fully understand it. But yeah, I mean, there are a lot of probiotics that I think you know, physicians probably could comment more about the use of probiotics.
There's a lot of work being done in Parkinson's disease right now with this. That's the area that has the most activity. And there's no question that variations in the microbiome in the gut have an impact on the development and course and severity of Parkinson's disease. Definitely has an effect. I can't comment about Alzheimer's disease or other dementias. I just don't know.
Yeah, there hasn't been a ton that's been done in clinical studies. There has been, I think the team at Penn has done some work looking at that and looking at if they can change the makeup of the gut as a potential strategy. But as I think Dr. Gann said, this is a newer space in Alzheimer's. It's that connection of the gut-brain. It's really only been maybe the last 7 or 8 years, which seems like a long time in some ways, but actually really trying to understand the connection, what actually is the makeup, collecting that information, trying to measure that and then tie it into the immune system and the various changes that we see in the immune system and how that might be impacting the brain. It's rather complicated, and it's been rather complicated in terms of the model systems that are being tested. It is clear there's a connection, and there's a lot of work going on to try to understand what that connection is. And I know we had about 6 questions on that linkage, so I wanted to make sure we addressed it. Really great question here. That's, what does it mean to be at an increased risk for dementia? It's a great question.
Well, you can answer it as a mathematical issue or real life issue. Okay.
And my guess is the audience here is really more interested in real life. Yeah. Right? Yeah.
Okay. So when we talk about risk, we're talking about what's the probability of developing a condition at some time in your life. Okay, and so we put up, there are a lot of slides from everybody talking about risks, and you can put a number on it. So for example, what we talked about with lifestyle modifications, if you, and this is my opinion, although I base it on a lot of work that other people have done, that I believe that if you effectively implement those 8 lifestyle interventions that I talked about, if you effectively do that starting middle life, you will reduce your risk of developing dementia by 50%. That's a big number. Drop the probability by half. Okay, I believe that. And you're nodding, so I guess you believe that too.
So there was a Lancet commission that actually looked at a number of factors kind of throughout life, and what they showed based on the data, but also in a consensus report of that panel, was that you could reduce global dementia prevalence by 40% in modifying those risk factors. Right. And there's more than 8, but there's a number of them throughout the life course.
And then you talk about ApoE4. If you're homozygous for ApoE4, that increases your risk of developing dementia, Alzheimer's disease, at least 10-fold. I've heard there are different numbers. Some people said
depends on the study.
18-fold, 20-fold. I mean, it's a very high risk, and the risk is at an earlier age, more rapid progression, and that's what that means.
Great, thank you. So hopefully that was you want to add something?
I just wanted to just add sort of how we look at it in the neurology practice, just for people who are coming in, who is really considered a higher risk, is if there is, as Dr. Fink just pointed out, ApoE4 carrier one copy or 2 copies, but APOE4 gene, age, so aging is a risk factor, family history is a risk factor. Those are probably 3 of the biggest known risk factors that are taken into account. And then, there's the risk of a lot of people are getting the amyloid testing. And so there are a lot of questions that come, from just what happens if I've had a scan and it's positive. And so that's really a big question for people in the community. And so what we know about that is that, there's a big difference between people who are actually not having current cognitive symptoms and are amyloid positive, and those who are having cognitive symptoms and are amyloid positive. So just to kind of briefly touch on that, and I think Dr. Snyder, you've already talked about this, that just, or actually Dr. Yes, that if you have amyloid in your brain, you don't, it's not clear that it's actually going to lead to developing dementia. These other risk factors sort of play a role. Some of these other things that really ties in all these talks, some of the vascular and other things that might happen, inflammation, that may help compound the process towards ultimately developing dementia and the co-pathologies. But really, the trying to keep it as brief as I can, the point that I'm trying to make is that if you have no symptoms and you go somewhere and get a test that says you have amyloid, you might have up to 30% chance in your lifetime to develop Alzheimer's dementia. But if you have memory decline, you actually have symptoms and you have amyloid positive tests, then you have a very, very, very high risk, 60 to 95% risk that you will develop Alzheimer's dementia. So that's a big distinguishing point also in assessing that risk.
So a couple questions here, and maybe I'll ask, well, anybody can answer this one. There's a couple questions here in terms of the hypertension medications and dementia risk. Are any more ideal than others? What do we know about that?
That's a very good question. There are definitely newer classes of medications. I would say that one can find in the literature pros and cons of almost all classes, and there are many. And you can find that diuretics and calcium channel blockers are protective. However, there is really quite a big body of evidence that the newer antihypertensive, like angiotensin receptor blockers, might be, I'm not saying that it's absolutely definite, might be particularly helpful, mostly because besides lowering blood pressure, they are also acting on many other pathways in the brain which are related to cognition and vascular regulation. So their action probably is related to much more than just lowering blood pressure. Also, I would like to add to the question about the gut microbiome, besides direct connection, which we are always very likely to go for between gut and brain, we must remember that also healthy microbiome will, I wouldn't say make healthy, but increase likelihood of healthy metabolic risk factors. So through this connection, indirectly also might increase brain health. It's been shown that clearly the microbiome has been related to body mass index, to hypertension. So if we make microbiome more healthy, or what's now seen as more beneficial, we will improve these conditions and through this the brain.
Yeah, I mean, I think it's the interplay. If we think about our brains as the control center, and they're really controlling everything, right? So our immune system, our metabolic system, how we're processing food, how we're processing energy in our brain, all of these pieces and how they're coming together. If they're not healthy, that's going to impact our brain in some way. I think what you're hearing here is that pieces of really that underlying, the building blocks of the biology that are how those things piece together. And as we understand more and more about that, we have new targets for potential intervention. Again, whether it's behavioral modifications, interventions, or medications of some sort to target that. Sometimes it might be things like, as you heard Dr. Fink say, that start in midlife and really putting all of that together. And it's that big puzzle that we're continuing to move forward and really fit those pieces together. Dr. Gann, one of the questions here is, and I'm going to direct it to you, even though this wasn't what your talk is, just because I happen to know a little bit more about your work and your background. And one of the questions here is around tau, and in thinking about tau. And, there's been a lot of advances, and although we didn't talk about it today, there's been a lot of advances in being able to take a picture of tau, although specifically only the tau in Alzheimer's, maybe measuring tau in the blood. But if somebody says, we don't know enough about tau to really say anything about what is happening in the brain or the disease, can you talk a little bit about that? Because I think that's probably true in the clinic, but can you talk about it from the biology? Because we're going to start to see that translate to the clinic. We're not quite there yet. Can you talk about that?
Yeah, actually, I took that out because for the sake of the time.
I know.
Yeah, so I think the A beta, so one way to, as an analogy, is A beta is the trigger and tau is the bullet in terms of the injury. So you can use that maybe imperfect analogy to emphasize, highlight, underscore the importance of tau in causing neuronal injury. The propagation of tau inclusions very much coincides with the cognitive decline. Basically, where tau goes, where damage occurs. And that also is showing up in the imaging, that where tau, using K tracers, you can know where tau is in the brain, and that's where the blood flow is reduced. So mechanistically, this is what we are trying to piece together, how to remove tau, how to reduce toxicity. And there are many ways. There is an antibody that people have been developing to try to remove tau, and that is in clinical trials. So far hasn't succeeded, but remember, amyloid antibody also took many trials. There are also ways to understand what are the toxic species of tau. Tau is a normal building block of the brain. When tau becomes bad, we need to identify why it becomes bad. So that will be another whole hour of lecture. But
Yeah.
what I'm saying is, yes, tau is a very important target, and I think Dr. Snyder said there are already clinical trials. And tau is a highly immunogenic. It actually triggers inflammation that I talked about. It also can trigger demyelination. So it is an agent of damage that we need to intervene.
And I think some of the work on tau, tau, we talk about it like a single thing, but it actually is incredibly complicated. It can be 3 repeats, it can be 4 repeats, so it's different sizes, the ratio of the 3 and 4, and where it is in the brain, incredibly complicated. And there's been a lot of work to really uncover that and understand it.
Yeah, so we use human neurons to model tau, and we also look at both difference between 3 repeat and 4 repeat. We also look at post-translation modifications to identify the toxic species. So there are a lot going on, and not just my lab, of course, there are many labs in the world fighting against tau.
So I think there's a ton, so just to that question, there's a lot happening that's in that space to really understand tau. Maybe it's not yet all at the clinical interface and in terms of interventions that are targeting tau, but there is a lot of work to really understand it. And there's a ton of trials that are going on and a lot of tools for biomarkers to measure tau, because tau is actually not only playing a role in Alzheimer's, it's actually in Lewy body dementia, frontotemporal dementia, it's in Parkinson's disease dementia. And so we really see that it plays a role in a number of these diseases that cause memory impairment. I know I have like 2 minutes, I think, but I have a lot of questions. So for anybody that's in the room, if you have additional questions, I'm sure anybody would hopefully maybe be willing to. We've got a lot of questions from people that are here, Julia, so I'm going to take those. But one of them is maybe to you, Dr. Fink, or actually to any of our clinicians. How does treatment of vascular dementia differ from Alzheimer's? Because I do think we talked a lot about vascular dementia, but we didn't necessarily talk as detailed about how you would treat individuals.
From my perspective, it's easier to treat vascular dementia because we understand the pathophysiology and the cause better. So we focus very, very deliberately on all of the vascular abnormalities that the person has. And we can treat all of those very aggressively. And my experience has been that if the cognitive impairment is not too severe, that we are pretty successful at arresting progression and stabilizing the condition in a way that has been more effective than in patients that really have Alzheimer's pathology. So, my perspective, it's a more manageable and treatable disease if it hasn't gotten too advanced. If it's very advanced, it means that there's a lot of ischemic damage all throughout the brain. You can't do very much. So, like everything else, you want to catch it early.
But I will say there are ongoing clinical trials that are also trying to even get at people that are experiencing memory changes that have vascular dementia. I know there's a team in Canada that's running a number of them, and I think there's some like locally here as well that are ongoing. So really encourage you, as a thinking about that. Clinical trials are always an opportunity to get involved in thinking about kind of that next generation of clinical research or what that next generation of treatments are. I'm going to take the moderator's prerogative because there's a lot of questions we're not going to get to, and apologies to those on the phone. I got to as many as we could and tried to put them together, but there's a few different ones here that are on different kinds of treatment, so or different kinds of approaches to treatment. So I'm just going to take 30 seconds and talk through some of those. One of them was around Ozempic, and could that be around weight loss and some of that management? Absolutely. We don't know if that's going to be direct, but the trial hasn't reported out. So we also don't know if there's a benefit. So that's something that's why trials are so important. We don't know the risk. We don't know the harms. And that's what we learn in clinical trials and in clinical research. The volunteers of clinical research are my heroes. They are incredible people. They are why we have any medication or anything that we have. They're why we understand these diseases so much more is because of their contribution to science and to learning in some of that. So that those trials are ongoing right now, and we don't understand all about the biology and the mechanism, and that's some of what we're looking to do. Another question's on hyperbaric oxygen therapy and whether it's effective. There are trials that are looking at that. It's actually, there's one led by a researcher that was at Mount Sinai and is now at Rutgers that's looking at that as a potential treatment strategy that's going on. Again, well, it's really important to do the study to find out. We don't know the benefit. We also really don't know the risk. So super important to ask those kinds of questions. There was another question in the chat around Prevagen. This is something we hear a lot about. This is something that's on the market. It's a direct-to-consumer on the market. And again, ask those questions. Has it gone through the rigorous review? Do we know the benefits? Do we know the harm? And in this case, it hasn't gone through that type of rigor or that type of testing. It's always a personal decision. Have that conversation with your provider about what is right for you and what makes sense for you. There could be interactions with other medications, but there's no evidence that it stops or slows the progression of the disease. A couple others are around the medications that are for symptomatic Alzheimer's and whether they help the brain. They help to turn up the volume on the brain cells to talk to one another as long as possible, but there's no evidence they're stopping or slowing the underlying progression of the disease. And I think that is my 30 or 45 seconds, and I got through about 6 or 7 of those additional questions. So apologies to everybody that we didn't get to your questions. And I'm going to pass it over to Michelle.
That was a very impressive lightning round to sum up our evening. So thank you, Dr. Snyder, for that. And thank you to all of our panelists for helping to plan the program and share so much really meaningful information today. We just want to close out and make sure that all of you know what we're here. We talked a lot about the big picture research and what's funded. A lot of this research is happening right here in New York City. We have some of the funded researchers on the panel. We have a number in the audience here today. Exciting to be at a place where so much meaningful work is happening. And as Dr. Snyder just mentioned, this can all happen because we have folks that are involved in clinical trials. So for those of you in the audience, to be aware that the Alzheimer's Association has a service called Trial Match. Super easy to log on our website to find out about different clinical trials that you may be eligible to participate in. We also want you to know how we can help. Today was a deep dive into research because there's so much exciting stuff happening, but many people in this room are living with these challenges now with yourself, your family, your communities. The Alzheimer's Association has a 24/7 helpline available around the clock, staffed by trained clinicians and specialists that we are here when you need us around the clock. And our website is a great source of comprehensive information. You could see everything from some of the research highlights that were talked about today to information about all of our care and support services. And right here in New York City, we're fortunate to have a really substantial chapter with a large program staff and a number of volunteers that are giving our education and programs out in community. So we are here if you need us. If you did not take information on the way in, please take some on the way out. And we'd love to find different ways for you to get involved with us. So there's tons of opportunities to volunteer and be engaged. But we're mostly just so pleased that you came here today. So thank you to all of you for joining us. We do have a brief post-event survey, which is in a number of places. It's on your agenda. It's here on the screen. And when we send a follow-up email out to all attendees, we'll share that as well. Please share our feedback with you. We're so excited to do programs with this, but we want to address your needs and questions as best we can. And with that, thank you all so much for coming. Have a safe and lovely night.